Good morning, everyone. Welcome to the Orlando GI Journal Club. This is August 7th, 7 a.m. Eastern Standard Time. Welcome, everyone. So the first study was published at the New England Journal of Medicine, and it is looking at stress ulcer prophylaxis during invasive mechanical ventilation. Critically ill patients are at risk for stress-induced GI ulceration and subsequent GI bleeding. Therefore, ICU patients receive acid suppression to prevent GI bleeding. Prior meta-analysis have shown that acid suppression reduces the risk of upper GI bleeding among ICU patients, but had no effect on mortality for prophylactic agent. However, there is a potential harm with PPIs, and the harm from PPIs could not be ruled out regarding risks of healthcare-associated pneumonia and C. diff infection. So the aim of this study was to evaluate the efficacy and safety of PPIs in ICU patients. So these authors conducted a multi-center, blinded, randomized trial at 68 hospitals in Australia, South America, Europe, Asia, North America. They included adult patients who were undergoing invasive mechanical ventilation in the ICU, and patients were randomized to either pantoprazole, intravenously administered once daily, or placebo, which was normal saline. The staff administering PPI placebo, patients, clinical and research staff, and outcome adjudicators were blinded to the type of treatment given for 90 days or until discontinuation of the invasive ventilation or death. The study had two outcomes, an efficacy outcome and a safety outcome. The efficacy outcome was the occurrence of clinically important upper GI bleeding, defined as overt GI bleeding with hemodynamic compromise, or requiring therapeutic interventions in ICU at 90 days. The primary safety outcome was death from any cause at 90 days. So 2,417 patients were randomized to pantoprazole, 2,404 patients randomized to placebo. As you can see, the mean Apache scores were 21.8 and 21.7 respectively. The majority of patients admitted to the ICU had a respiratory illness, followed by trauma and a cardiovascular disease. The proportion of patients who had glucocorticoid therapy more than a week before randomizations was about 35%. And invasive mechanical ventilation obviously was administered in all the patients, and 69.5% and 71.1% of patients on pantoprazole and placebo respectively had inotrope or vasopressor infusion. 6.3 and 6.4% of patients were undergoing renal replacement therapy. The primary outcome, when we're looking at the primary efficacy outcome of the occurrence or incidence of clinically important upper GI bleeding, they found that the incidence was 1% in the pantoprazole group compared to 3.5% in the placebo group. This gives an absolute difference of 2.5% and a hazard ratio of 0.3, which was statistically significant with p-value of less than 0.001. When looking at the primary safety outcome, 90-day mortality, the incidence was similar between two groups at 29.1% in pantoprazole compared to 30.9% in placebo, and this difference was not statistically significant with p-value of 0.25. These authors then looked at secondary outcome measures, which included the incidence of ventilator-associated pneumonia in the ICU, C. diff infection, need for new renal replacement therapy, and then total occurrence of death in the ICU and in the hospital, and patient-reported upper GI bleeding in the ICU. So they found that there was no significant difference between either the incidence of pneumonia, C. diff infection, need for new renal replacement therapy, or the rate of death. And when they looked at the incidence of patient-important upper GI bleeding in the ICU, however, this incidence was also significantly lower in pantoprazole group at 1.5%, compared to 4.2% in the placebo group, with p-value of less than 0.001. The tertiary outcome measures included the median number of red cell units transfused in the first 14 days in the ICU, the median peak serum creatinine levels, the median number of days on mechanical ventilation, the number of days in the hospital, and days in the total days in the ICU and the hospital. And there was no significant difference between these two groups in all those tertiary outcome measures. The main limitations of this study is that they had no patient-reported disability outcomes reported in this trial, and there was no data on microbiome modification as a mechanism for infection risk. So in this randomized trial, among critically ill patients undergoing invasive mechanical ventilation, use of pantoprazole resulted in a lower risk of clinically important upper GI bleeding than use of placebo, with no overall effect on mortality. Okay. Our next study is also published in the New England Journal of Medicine. This is looking at risankizumab and ustekinumab for moderate to severe Crohn's disease. Anti-TNF therapy is the preferred first-line advanced treatment for moderate to severe Crohn's disease. And the selection of an alternative biologic agent in patients with inadequate response to one anti-TNF agent is based on indirect treatment comparisons and observational studies. Ustekinumab and risankizumab are humanized IgG1 monoclonal antibodies that bind to components of pro-inflammatory cytokine interleukin-23. The efficacy and safety of risankizumab and ustekinumab in patients with Crohn's disease are, however, unknown. The aim of this randomized trial was therefore to compare the efficacy and safety of risankizumab and ustekinumab in patients with moderate to severe Crohn's disease in whom at least one anti-TNF treatment had failed. This was a phase 3b multi-center open-label randomized trial involving 187 centers in 28 countries. Adult patients aged between 18 and 80 with moderate to severe Crohn's disease of at least 3 months duration before enrollment and had unacceptable side effects with at least one anti-TNF therapy or inadequate response to at least one anti-TNF therapy were included in the study. The definition of moderate to severe Crohn's disease in the study was the baseline score of 220 to 450 on Crohn's disease activity index, mean of at least 4 on a daily stool frequency, or mean score of at least 2 on daily abdominal pain scale, and simple endoscopic score for Crohn's disease, SES-CD of at least 6 for ileocolonic or colonic disease. The patients underwent mandatory glucocorticoid taper initiated at week 2 per study-specified tapering schedule. The patients were then randomized in a 1-to-1 ratio to either risankizumab or ustekinumab. The primary outcome measure was clinical remission at week 24 and endoscopic remission at week 48. And clinical remission was defined as the Crohn's disease activity index of less than 150, and endoscopic remission was defined as SES-CD of 4 or less, and decrease of at least 2 points from baseline, and no subscore greater than 1 in any individual variable. Okay. So 255 patients were randomized to risankizumab. 265 patients were randomized to ustekinumab. 46.7 patients in the risankizumab were female, 50.6% in the ustekinumab were females. The mean age was 38 in both groups. The majority of patients were white. The mean body mass index was 24 in both groups. 43% of patients had ileoclonic disease, 40% had clonic disease only, and about 17% of the patients had ileal disease only. The median CDAI score was 306 in the risankizumab group and 307.8 in the ustekinumab group. And the mean duration of disease was median duration of disease was 7.3 years in both groups, ranging from 0.3 to 40 years. And the risankizumab group, and the range was 0.3 to 51.9 years in the ustekinumab group. The median abdominal pain score was 2. The median stool frequency was 5. The median SES-CD was 12 in both groups. The outcome measure, when looking at the primary endpoint of clinical remission at 24 weeks, risankizumab was non-inferior to ustekinumab at week 24, as you can see here. And when looking at endoscopic remission at week 48, risankizumab was superior to ustekinumab at week 48, with p-value of less than 0.001. When looking at secondary endpoints of clinical remission at 48 weeks, again, risankizumab, the scores were higher in the risankizumab group at 60.8 versus 40.8 in the ustekinumab group. Again, endoscopic response at 48. Scores were higher in the risankizumab group at 45 versus 21.9 in the ustekinumab group. And when looking at glucocorticoid-free endoscopic remission at 48 weeks, again, it was superior in the risankizumab group versus ustekinumab group with p-value of less than 0.001. And when looking at, again, glucocorticoid-free clinical remission at week 48, risankizumab scores were higher at 60.8 versus 40.4 in the ustekinumab group. When looking at the adverse events, when they looked at serious adverse events, the number of patients or proportion of patients encountering adverse events was 16% in the risankizumab group compared to 19.2% in the ustekinumab group. When looking at the adverse event leading to discontinuation treatment is 3.8% versus 4.9% in the risankizumab and ustekinumab groups, respectively. The main limitation of this study is that it was an open label design, which could have influenced the reporting of symptoms and safety events. Otherwise, it was a strong study with a large study. So in summary, in this randomized trial of risankizumab and ustekinumab involving patients with moderate to severe Crohn's disease who had unacceptable side effects or inadequate response to anti-TNF therapy, risankizumab was non-inferior to ustekinumab for clinical remission and superior to ustekinumab for endoscopic remission. No new safety risks were identified in association with risankizumab. Our next study is looking at glucagon-like peptide-1 receptor agonists. These authors conclude that they do not increase aspiration during upper GI endoscopy in patients with diabetes. And this is by Barlow et al. Published in CGH this month. So glucagon-like peptide-1 receptor agonists, GLP-1 agonists, are increasingly used for treatment of type 2 diabetes and obesity. GLP-1 agonists have been associated with nausea, vomiting, and delayed gastric emptying. However, there is minimal controlled population-based data evaluating the potential adverse events of GLP-1 agonists in the periprocedural setting. However, despite the limited evidence in this area, the American Society of Anesthesiology has published consensus guidance to hold GLP agonist administration on the day or week before elective procedures, and if the patient is taking GLP-1 agonists, to treat them with full stomach precautions or delay the procedure. The aim of this study was therefore to determine if there is increased risk of aspiration and aspiration-related adverse events after upper GI endoscopy in patients using GLP-1 agonists when compared to dipeptidyl peptidase 4 inhibitors, which have similar mechanism of action to GLP-1 agonists, but with negligible effect on gastric emptying, and chronic opioids, which again causes similar delayed gastric empty effects as GLP-1, but without specific periprocedural guidelines. This was a retrospective cohort study using nationwide commercial administrative claims database, known as the Truven Health Analytics Market Scan database. And this database contains health insurance enrollment information and inpatient outpatient pharmacy data for around 20 million private health insurance beneficiaries annually from 100 commercial payers. So these authors included patients aged 18 to 64 with type 2 diabetes who underwent outpatient upper GI endoscopy from 2005 to 2021. The primary outcome measure was to compare the claims for aspiration and associated pulmonary adverse events in 14 days after upper GI endoscopy between users of GLP-1 agonists, DPP-4Is, and chronic opioids, with adjustment for age, sex, Charlson comorbidity score, underlying respiratory disease, and gastroparesis. So these are the number of patients analyzed in this study. 15,000, just over 15,000 GLP-1 agonists, 14,000 DPP-4I users, and 7,200 patients on opioids. And if you look at kind of the general median age, again, similar across the board, median age of 55 in GLP-1, 57 in DPP, and 56 years old in opioids. We're looking at proportion of gender. 60% of GLP-1 users were female, 52% of DPP-4I users were 53%, 53% of opioid users for females. When looking at the presence of COPD, 3% in GLP-1, DPP-4Is, 8% in opioids, gastroparesis present in 1% of GLP-1, DPP-4Is, and opioid groups. When looking at the incidence of the outcome measures, so looking at the incidence of aspiration pneumonia, just pneumonia, respiratory failure, pulmonary adverse events, hospitalization, and ER visits. What they did was they looked at the incidence in each of the groups, and then they compared GLP-1 versus DPP, and then GLP-1 versus opioids. So if you look at the unadjusted risk ratio for aspiration, you can see that for GLP-1, it was risk ratio was 0.67 with a 95% confidence interval 0.25 to 1.74. When looking at instance of aspiration, comparing GLP-1 to opioids, risk ratio was again 0.42 with confidence interval of 0.15 and 1.16. So when the confidence intervals for the risk ratio spans 1, it means that there is no increased risk of this event happening with GLP-1 compared to DPP or compared to opioids. When looking at, again, as incidence of aspiration pneumonia, looking at the risk ratio, 0.95 with 95% confidence interval, 0.4 to 2.2 when comparing GLP-1 to DPP-4, And when looking at, when comparing GLP-1 to opioids, again, the risk ratio was 0.6 with the confidence interval ranging from 0.24 to 1.52. So if you look at all of these incidents, all these adverse events of pneumonia, respiratory failure, pulmonary adverse events, hospitalization, and ER visits, if you look at all these 95% confidence intervals, both unadjusted and adjusted, they all span 1, as you can see here, when comparing GLP-1 to DPP and when comparing GLP-1 to opioids. So they also performed a sensitivity analysis to exclude people who were on multiple drugs. And again, there was no significant difference really in the risk ratios for GLP-1 for occurrence of any of these adverse events when comparing GLP-1 to DPP and when comparing GLP-1 to opioids. So the main limitation of this study, obviously, is that this is a retrospective study with its inherent risk of bias. Newer, more potent GLP-1 agonists were not included in this analysis owing to data extending only to 2021. They also excluded GLP-1 users who used it exclusively for weight loss to minimize between group variability by focusing on patients with type 2 diabetes. They evaluated also prevalent medication users as opposed to incident users, which raises the possibility of prevalent user bias and possible tachyphylaxis of long-acting GLP-1 mediated delayed gastric emptying. However, when they looked at the incident users within 6 months before the index EGD with a washout period, or overall findings were similar. So the main take-home point from this study is that using a national insurance claims database, patients with diabetes prescribed GLP-1 receptor agonists did not have an increased risk of post-EGD aspiration event compared with DPP-4I or chronic opioids. And given the rarity of post-EGD pulmonary events and lack of increased risk in this group of patients, measures to further decrease risk of aspiration in GLP-1 agonists may not be merited. Our next study is looking at the hydration strategy using lactated ring solution for post-ERCP pancreatitis prevention. This was a randomized trial published by Cho et al. In the Red Journal. So post-ERCP pancreatitis is a recognized complication of ERCP. Aggressive hydration with a lactated ring solution has been shown to prevent the development of post-ERCP pancreatitis. However, on the flip side, it may lead to volume overload and pulmonary or peripheral edema, and optimal timing and volume of IV fluids have not been well defined. So the aim of this randomized trial was to evaluate the effect of tailored hydration in early occurrence of abdominal pain or serum amylase elevation in the prevention of post-ERCP pancreatitis. This was a multi-center, double-blind, randomized trial conducted at 3 tertiary hospitals in South Korea. Patients 20 years or older who were undergoing ERCP for the first time were randomized in a 1-to-1 ratio to the following: either to a tailored standard hydration, which meant that they were given lactated ringers at a rate of 1.5 milliliters per kilogram per hour during the ERCP and for 4 to 6 hours after the ERCP, versus tailored aggressive hydration, where they're given 3 milliliter per kilogram per hour during ERCP, and then they were given a 3 milliliter per kilogram bolus after the procedure, followed by 20 milliliter per kilogram per hour post-ERCP for 4 to 6 hours. Let me just check something. No, they were given, I apologize, they were given, I thought that sounded funny, 3 milliliter per kilogram. They went back to 3 milliliter per kilogram per hour post-ERCP for 4 to 6 hours, not 20 milliliter. Both groups were assessed for epigastric pain or serum amylase at 4 to 6 hours post-procedure. If none were present, IV fluids were stopped. If one or both of these were present, hydration were continued at the usual rate of total of 8 hours. Then at 8 hours post-procedure, if the criteria for post-ERCP pancreatitis were met, determined by abdominal pain and amylase elevation of at least 3 times the upper limit of normal, aggressive hydration was performed for 24 hours at rate of 3 milliliter per kilogram per hour. The primary outcome measure was the incidence of post-ERCP pancreatitis, which is epigastric pain and elevation in amylase at least 3 times the upper limit of normal at 20 hours post-procedure, requiring hospitalization for at least 48 hours. So 171 patients were enrolled in the standard hydration group. 173 patients were enrolled in the tailored aggressive hydration group. And when looking at the baseline characteristics, the mean age was 61 in the tailored standard group, 58.9 years in the aggressive hydration group. 39% of patients in the standard group were female, 45.9% in the standard group, in the aggressive group were female. Nobody had a history of recurrent pancreatitis. The main indication for ERCP was choledochondrosis, followed by malignant biliary obstruction. Difficult cannulation was defined in 1.2% in the standard group, 4.5% in the aggressive hydration group. Precut access was required in 16% of the standard group and 13.4% of the aggressive hydration group. PD injection was performed in 2.4% of the standard and 2.9% of the aggressive hydration group, and pancreatic stents were placed in 20% of the standard hydration group and 13.4% in the aggressive hydration group. So when looking at the primary outcome measure of the incidence of post-ERCP pancreatitis, the occurrence was 9.4% in the tailored standard hydration group compared to 3.5% in the aggressive hydration group. And this difference was statistically significant with p-value of 0.03. When looking at the secondary outcome measures, so they looked at the severity of post-ERCP pancreatitis. So there was moderate to severe acute pancreatitis occurred in 1.2% of the standard group, 0.6% of the aggressive hydration group, and this gave p-value of 0.57. And when looking at post-ERCP pain at 24 hours, this occurred in 26% of standard versus 15.7% of the aggressive hydration group. And this was, again, statistically significant. Total volume of fluid given was 1.1 liters in the standard group, 2.8 liters in the tailored aggressive hydration group. The length of hospital stay was no different, however, 6 days median, with interquartile range of 4 to 8. The incidence of volume overload was 0.6% in the standard group, and funnily enough, 0 in the aggressive hydration group with p-value of 0.32. When looking at other ERCP-related complications, overall it was 1.2% in standard, 2.3% in the aggressive hydration group, and this was not different between the two groups. The incidence of bleeding was 0.6% in the standard, 2.3% in aggressive hydration group, and there was one patient with cholangitis in the standard hydration group. There were no deaths in the study. So the main limitation of this study is that rectal indomethacin was not used in this trial because it is not commercially available in South Korea. The use of pancreatic stenting, which is a known maneuver to minimize the risk of post-ERCP pancreatitis, was left at the discretion of the endoscopist. And also the treating physician and nursing staff were not blinded to the randomized to the group allocation. So tailored aggressive hydration with lactated ring solution administered according to the probability of post-ERCP pancreatitis at the 4 to 6 hour assessment post-procedure was safe and effective method for preventing post-ERCP pancreatitis. So in summary, among critically ill patients undergoing invasive mechanical ventilation, use of pantoprazole resulted in a lower risk of clinically important upper GI bleeding than the use of placebo, with no overall effect on mortality. In this randomized trial of risankizumab and ustekinumab involving patients with moderate to severe Crohn's disease who either had unacceptable side effects or inadequate response to anti-TNF therapy, risankizumab was non-inferior to ustekinumab for clinical remission and superior to ustekinumab for endoscopic remission. Using a national insurance claims database, patients with diabetes prescribed GLP-1 agonists did not have an increased risk of post-EGD aspiration events compared with DPP-4I or chronic opioids, and given the rarity of post-EGD pulmonary events and lack of increased risk in this group of patients, measures to further decrease the risk of aspiration GLP-1 agonists may not be merited. And finally, tailored aggressive hydration with a lactated ring solution administered according to the probability of post-ERCP pancreatitis at 4 to 6 hour assessment post-procedure was safe and effective for preventing post-ERCP pancreatitis. Thank you again for joining us this morning. Our next journal club will be the first Wednesday of September, which is September 4th, 2024 at 7 a.m. Eastern Standard Time. Thank you so much. Please have a wonderful day, week, and month, and we'll see you in September. Goodbye.